Okay, cool. Okay, so I'm going to cover looking at hamstring injuries from acute care to return to sport. So come for the whole journey, right from commencement right through to return to sport, and some of those criteria for return to sport, and how we need probably to get better. And some of those issues Dr. Hammond was talking about are so important and are so badly done in sports physio. So I'm going to, if you give me some leeway as I go through, present some of my thoughts on some of these areas about where we maybe need to change what we're doing. So my role as outlined is I'm Associate Professor at the University of South Australia. I'm also Program Director of the Masters of Advanced Clinical Physiotherapy, which includes both the musculoskeletal and a sports stream. So we have two different streams involved. So hamstring injuries are a major issue, and as so well defined and described, there's a really nice study by Extra and al. Did a 13-year study of 36 football clubs in 12 European elite leagues. They found about 22% of players sustained at least one hamstring injury. So 1/5 of the total player group actually had a hamstring injury over the time period they were playing. Injury rate was about 1.2 injuries per 1,000 hours. And one thing I felt really interesting was that the match injury rate was 9 times higher than the training injury rate, which comes back to trying to work out the preventative aspect, look at what the demand within a game compared to training. I think the effort aspect to it and the fatigue plus effort, and that becomes really important in rehab, in that we need to rehab the effort and the fatigue, the 110% effort in rehab before we go back on the game, because the injury rate is so much higher in matches than it is in training. And interesting, from this study, the average hamstring injury burden was 19.7 days. In Australia, we have the Australian Football League, which is our major national football competition, and it's Australian rules football, completely weird sport. If you're not Australian, if you grow up with it, it makes sense. But our injury rate is 21 days, so it's very similar as far as the disability results from the average hamstring injury. So it was, as I said, in Australia, it's a major issue. We're having a significant issue in Australian rules football with hamstring injuries. This report from 2018, the end of 2018, so it hasn't improved since then. But what I found interesting in this report was that there was, as I was saying, there's no fewer than 30 players across all the AFL clubs who are out at any one time with a hamstring injury, which is a major burden. Out of our, I think there's 14 clubs, 14 teams in the National League. There's 18 players per team, so there's almost a team and a half out every week with hamstring-based injuries. But what I found interesting was that it was just 2 NRL players, and the NRL's a National Rugby League, a different form of football. Aussie rules, Australian rule footballs tend to have a significantly higher incidence. And I want to talk about possibly why that is and why we need to look at, probably the evidence, I suppose, and how we need to look at how we apply the evidence associated with hamstring prevention programs, particularly to be specific to the sport. Okay, so let's talk a little bit about hamstring mechanisms, because it's really important. The first part of a hamstring injury process is the assessment, is to really identify when did it occur, and that thinking must follow through very much along the idea of Maitland's make features fit. So it needs to, if you follow up with the patient about what caused the injury, that should link to the area of injury, then the rehab will be directed along those lines. So it very much comes back to subjective and objective examination at the beginning. So the history, looking at normal running cycle, at foot strike, the biceps femoris and semimem contract to stabilize the knee. Once you get mid-support to heel rise, when you're really looking at that power push, particularly in running, is when the biceps femoris comes in quite significantly at that point. There is some semi-10 semimembranosis, but really the biceps is the force, the muscle, particularly the short head and the biceps, to really give you that power to push off in the running cycle. At the end of swing phase, when we're trying to control the forward movement of the leg, then we have a strong eccentric contraction of the semi-10 semimem. So what we should be seeing is that the history of the injury often reflects where it occurred, or the type of injury that presents occurs along with where it occurs during the running cycle. That makes sense, and then it follows with a hamstring injury. As soon as stuff doesn't fit with that, then we need to look deeper into the differential diagnosis. So types of injuries that we see, swing face injuries in running are usually at the end of the swing phase, that eccentric loading. Commonly the biceps femoris long head, or the semimembranosus, semitendinosus, because they're eccentrically contracting at that end. But the injury is usually at the distal part, so it's closer to the knee. When you have that takeoff injury, which is when the biceps femoris comes off from mid stance to toe off, when we're trying to push ourselves forward in the running, then usually it's a biceps femoris short head, so it's quite high up in the hip joint. With kicking, which is a big issue in football, obviously it's eccentric. Again, semitendinosus, semimembranosus, when a patient talks about kicking or with their leg out front. And I put those terms next to knee, hip, and knee there to get an idea where the injury site is, to give us an idea when we're looking at rehab from the early to late, where the emphasis should be. When we're dealing with a two-joint muscle, if we're looking at an eccentric loading injury, a swing phase injury, which is at the distal part of the hamstrings, then we can start rehab earlier on using the biceps joint and not using the knee joint to start movement happening without overloading the area of injury. But likewise, the other side of the equation, if we have a higher injury, such a biceps injury, then we can use knee hamstrings at the knee to load the hamstrings, but not so much that they override and cause problems in the early stages. But then likewise, when we rehab down the end, we need to make sure we rehab specific to the demands that are in place. So if we've hurt ourselves with the takeoff and the hip side, then we need to rehab on that hip aspect. So some of the risk factors from the literature associated with hamstring injuries. And Dr. Heyman said beautifully, poor rehab is one of the probably the major issue. The greatest prognosticator for an injury is a previous history of an injury. So that usually relates to poor rehab and an understanding of the period of rehab. We take rehab as symptomatic when in fact when we look at the remodeling phase of type 3 collagen through to type 1, that can take up to 12 months. So for me, when I'm dealing with patients and athletes, particularly with hamstrings, you've got to give them the idea that it's actually a 12-month injury. Now, they will be back playing well, etc., but they will still need to be doing some form of rehab, either some more stretching than usual, more training in that area for at least 12 months, because that's how long it takes for the type 3 collagen, which is usually laid down post-injury, to convert to type 1, which is reflective of a more mature collagen tissue, scar tissue. There's tight cells on the contralateral side, poor hamstring eccentric strength or endurance, reductions in flexibility, not only just in the muscle, but a prognosticator for hamstring injuries, neural tightness. So tightness in the nerve system can lead to problems with the recurrent injuries. And when we look at some of the codes, particularly again Australian rules football, where there's a lot more hip movement than in soccer, or sports where they have to bend down to pick the ball up from the ground, is effectively a slump, a modified slump activity. So as soon as you start stretching the neural tightness, the hamstrings jump in and injure themselves. And so the presentation's muscle, but in fact the underlying cause for the recurrence is often the neural tightness. There was a study done here probably about 30 years ago now, looking at patients with recurrent hamstring injuries. Unfortunately, it was post first injury, so it's difficult to know what was the early cause, but a very high incidence in the recurrent hamstring injuries, a very high number of patients in the hamstring injury thing had positive slump test. So that, when you rehab the muscle, if we don't rehab the neural tightness, then it'll come back again, the recurrence. So it's very much thinking about the other aspects, the risk factors. limited warm-up, fatigue, poor pelvic control is becoming a lot more, we're becoming a lot more aware now of the need for pelvic control, and the importance of pelvic control with good glutes, good adductor co-stability, the core stability, etc., to stabilize the pelvis, which is the foundation from which the hamstrings actually work from. So in both an open and closed kinetic chain activity. So the need to stabilize the pelvis. Now we're very much aware of it in the shoulder, and there's been a lot of work in that area in stabilizing scapula for shoulder function, etc. But we're becoming a lot more aware now that in fact the pelvic control is so important for lower limb overuse, and the controlling activity of the lateral rotators, the small external rotators in the hip joint, which helps stabilize the joint, also forms that solid foundation from which the hamstrings can have a solid basis from. If we lose that pelvic control, pelvic stability, then the hamstrings are working at an insufficiency or an inefficient way. Their base is unstable, so they have to work twice as hard theoretically. So we see that it's a higher risk factor of hamstring injuries for those patients with those athletes with very poor pelvic control. So it's something that we need to think about from a screening perspective, as well as we'll talk about later on some of the other screening aspects. Types of injuries, I think it's important to be aware of and think about the type of injuries that present, which will guide our management. So not all hamstring injuries are hamstring injuries. Not everything is the same. We know anatomically there are different sites, but also within the same anatomical sites, there's different presentation. We're becoming a lot more aware of in hamstring injuries, the issue of intramuscular tendon injuries. And these are the high recurrency, and the ones which tend to recurrent as well, tends to be ones where we can see there's actually an intramuscular tendon injury, because the hamstring tendon actually goes quite a way through the muscle. And this is where the new sensitive MRIs have been quite useful in Australian rules football, to differentiate those patients who need to go back early, who can go back early, and those who actually we're better off keeping back a little bit, because the tendon takes longer to heal, has a poorer blood supply, more likely to load with the eccentric program, so that we're using more sensitive MRIs to actually identify and differentiate those slower patients to the faster healing patients, because I think that's the important. There's also the different types of hematomas that form post-injury, which can also differentiate the intramuscular ones, where the muscle fascia maintains intact, so you don't get the same bleed out, if you like, and the hematoma actually is limited, but can actually form within the muscle tissue itself, and is at higher risk then of leading to an ectopic ossification. I've seen abscess form from tracking of hematomas that have been caught within the muscle and have had too much early active rehab, aggressive rehab. So we need to be wary of those ones which are self-limiting hematomas that form within the muscle. So you'll see there's a solid lump that forms. There isn't a lot of bruising outside, as opposed to the intermuscular hematoma, which ruptures the muscle fascia, and we see a lot more bleeding and bruising. So effectively what we say to the patient is, the worse it looks, the better it is, because you get a chance for that blood to go out. Blood's noxious to the body. It can be dealt with outside, got rid of, etc. We don't have the risk of formation of an abscess within the muscle. And like I said, that can lead to ectopic ossification issues, etc. So calcification issues. And then obviously the different grades, which I'm sure you're all aware of. So one thing, and this notion of failure point and that plastic deformation, which is what we want. This curve, this stress strain curve, is so important to not only understanding the management of the patient or the risk factor or why they hurt themselves, because the movement of that curve, when you have a very fast contraction, repeated contraction, it moves to the left, so failure point occurs earlier on. But it also helps direct us when we're talking about rehab in the early stages, where we want to be exercising in the relatively acute stage, in the inflammatory phases, in fact in the elastic region. Once we get over that and we're into the proliferative phase of healing, then we want to start getting to plastic deformation. So we want to push the stretches a little bit more. So we need to balance our inflammatory cascade with our stress strain curve. And we're going to talk about that as we go through in that. And that's part of that early management side. I think it's really important for differential diagnosis of the recurrent hamstring injuries that we really need to be on the ball early on and have these in the back of our mind when we're seeing that patient right at the beginning, on the side of the field, day 2 after the injury, etc., that you've got to have these in the back of your mind, because you don't want to miss these. You don't want to head off on the wrong rehab time, when in fact you should be looking at, you know, keeping an obviously a somatic referral from the lumbar spines. Not uncommon. The differentiator is the description of symptoms. Referral generally is vaguely, poorly defined pain. So ask your patient with a hamstring injury to put their finger on where it hurts. A hamstring strain should be able to put their finger on, yep, it hurts exactly there. Somatic referral will tell you it hurts around there, and they will rub, they'll use their whole hand rather than being really specific. Plus or minus lumbar symptoms, they don't always have them. I'm always amazed at how often they don't have anything, but what they will have is the lumbar pavum. So if you palpate in the lumbar spine, there'll generally be something positive, be it painful, etc., in the lumbar spine. So, you know, if you're getting that non-specific referral, it can be quite intense in the hamstring area, but they can't put a finger on it. Then I tend to also look at the lumbar spine and the SIJ, sacroiliac joint, as being potential for somatic referrals. And you know, the classic for the SIJ is the active straight leg raise. Get him to do a hamstring stretch actively and compress the pelvis just over the innominates on both sides. And if the pain goes away, then you know it's an SIJ. And I've had a couple in the university clinic which have been classic, who've been seeing physios outside. And one of the joys of working in university clinics or the chronic clinic is the patients had all the good physio outside. I don't have to do all that because that's already been done. So I remember one last year had strong hamstring pain post sporting injury, had seen the physios for 3 months on and off, etc., outside, had all the good hamstring rehab. And she was a classic when we did the active straight leg raise, because, you know, I had the benefit of being able to look for everything else. So I didn't have to worry about the hamstring because really good physios had done it all. Compress the innominates, the pain down the back of the leg went. And a belt on, teaching her core stability, etc., in a longer term, but putting a belt on in the short term really allowed her to go back to her sport, etc. So the sacroiliac joint can be hip joints. Somatic referral, again, the classic somatic referral of poorly defined, can't put a finger on it. They also may have hip symptoms, and hip flexion adduction is usually the test I would use to rule out hip. There's also usually with a hip joint a recurrent history. It's usually related to some degenerative change or a form of impingement in the hip joint, posterior impingement, and there's usually a history of recurrent aspects to it. Neural's a big one we need to be wary of, and you know, every hamstring injury I treat, I would look at, you know, by day 7 to 10, I'd be doing a slump on them just to clarify whether there's any neural tightness as either precursor or it's caught up in the healing process down the back of the leg. So definitely get into slump early on. Neurals are a differential diagnosis. Piriformis syndrome's a differential diagnosis. This is for a very high hip hamstring injury. Again, the area of symptoms will be more over the piriformis, and piriformis stretch will be positive. Femoral stress fractures can give you posterior thigh pain. Again, different description than purely a muscle stuff, usually related to high-level athletes, usually linked to some dietary, or in female athletes, dysmenorrhea, but alternatively dietary issues, etc. Long loading and femoral stress testing usually can give you an idea whether it's actually coming from the femur. Ischial apophysitis or avulsion fractures, usually younger patients, usually where the apophyseal plate has not formed, hasn't totally closed up as such, as still developing athletes. Sudden onset of pain, very high up, very painful, tender over the ischial tuberosity, very severe pain. I'd be thinking about both of those athletes as a differential diagnosis. Vascular damage, very rare, but compartment syndrome has been talked about. I've not seen one clinically, but you would be looking for symptoms down the leg. So they would be broader than just in the hamstring area. So you would be looking at uneven vascular flow between the left and right, patient reporting cold feet, cold legs, etc., poor healing, etc. Compartment syndrome is usually related to vigorous repeated activity. So so they're very rare, but you've got to get them in the back of your mind, particularly for that recurrent atypical type of hamstring presentation. I'm sort of really big on, and in our course, teaching the fact that you need to understand the healing process in acute soft tissue injuries to understand what's going on. And this is very much an average sort of guideline for the 4 phases of healing that we talk about. Bleeding for the first 72 hours in a very vascular structure such as the hamstring. Inflammatory, starts after 1 or 2 hours, peaks in a couple of days, and can last up to 3 weeks. The proliferative phase, where we're starting to actually get fibroblastic activity and angiogenesis, and we want to start really pushing the area, pushing the development, peaks 2 to 3 weeks, lasts 2 to 3 months. And as I said, the remodeling lasts up to 12 months. So that's very much a rough guide, very rough guide. And then what you do is look clinically at what the patient presents with to see where they sit. And this is the problem. Problem with human beings, I think, is that the theoretically, and when you read your textbook and what I presented you in the previous slide, it's very clear, very nice defined steps. The reality is it doesn't work like this. And within an area of healing, with a hamstring injury, you'll have, hopefully not the bleeding after 72 hours, but after 72 hours, you'll have some stages in the early inflammatory. Some have progressed through, maybe even starting proliferative phase, already starting to lay down. So you can have joints, within the same injury area, having different parts of the inflammatory cascade going on at the one time. It doesn't all work sequentially through in the whole injury area, again, depending on the extent of the injury. And so what we're doing clinically in physio is trying to work out, when we see the patient, where they are within that predominant inflammation, and using our rehab to help facilitate that progress through what is a normal process, an inflammatory cascade. So how do we know what the stage is? We know from the history, the behavior, and the clinical findings. So and we're looking at the early stages, increasing local pain. The throbbing nature of it suggests that bleeding stage. They can often have symptoms of shock associated with it. Very rare in a hamstring injury, but we need to be aware of it. Clinical findings, you'll see that sort of intermuscular hematoma, which is a rupture of the outside fascia. So we're now getting blood out of the interstitial, or outside the intramuscular area. So we're not going to get that localized hematoma formed. There may be a localized hematoma as well, but this is this picture here is from someone who's had a broader bleed, if you like. So they may have a bruise. They may have a swelling, a circumscribed swelling area as well, increasing tenderness and skin warmth. When we move into the inflammatory phase, the key with it is the achy nature of the pain. So the patient, when you're dealing with a hamstring rehab, is talking about an ache, who's talking about a latency of symptoms. So when I do something and it hangs around for a while afterwards, which we call irritability, but really talking about latency of symptoms. And important, and we think it's probably related to the myofibroblast activity, is that stiffness following a period of inactivity. So classic story with the hamstring, early hamstring injury, or any injury anywhere, is that they warm up, they're not too bad, they stop and rest. The first few steps are painful, stiff, sore once they learn. Now, if they've got that, they are still within the inflammatory phase. So we need to be a little bit careful and not push too hard in that stage, because they're still in an active inflammatory process. Though they may have acute swelling, may be fluctuant, may be warm, it's not always as obvious as that previous patient who would have had a very warm swelling. There'll be bruising, there'll be warm skin, resistance through range of movement, so it's a lot more thickening through range. Everything hurts, and there's a hyperalgesic associated with it. So often I always say within the first 2 to 3 days, it's near impossible, I think, clinically to really understand what's happened in an injury. The early hyperalgesia is secondary to neutrophils, secondary to neutrophils coming into the area, the bradykinins, the serotonins, the chemicals released as part of that inflammatory cascade, which hypersensitize the nerves in the area. So when you palpate, everything's going to be sore. So it's really important not to give the patient the worst case scenario. At that point, usually takes 5-6 days before it starts coming back, in my experience, down to a more localized, and then you're going to have a better idea of what actually happens. And that's the point that you're passing over the peak of the inflammatory cascade. Normally peaks in a couple of days, and you're starting heading towards fibroblast, towards proliferative in most patients. In that proliferative phase, there's less pain at rest, more localization of pain. As I was saying, the hyperalgesia settles down. Pain tends to come and go now. It's a really bad one. It may have been constant before. It's more intermittent, reduced latency, reducing stiffness. And I'll say, before it took 4 or 5 steps, 1 or 2 is up. So it's telling you that they're progressing nicely through the inflammatory process. But there's some area of them which is late inflammatory, early proliferative phase. Coming through to the next stage, you get reduced swelling, reduced bruising, normal skin temperature. So the active phase have gone, resistance towards end range, reduced area of tenderness. So we've all seen this process as they're progressing through. So as you're seeing the patient with it, make sure you're linking them back into where they are within the inflammatory cascade. So there's no pain at rest, localized pain, latency, irritability, no stiffness, more function, end range pain. So those patients we can be a lot more aggressive with than anyone who's proceeding where there's a latency of symptoms, etc. We need to be careful and respect that area. And what I see sometimes in physio practice, in particularly the management of these injuries, is sometimes we back off too long and we're too protective of pain when really, by the time we're getting to this stage, actually causing pain is not going to be a bad thing. Why we don't overdo it, but actually causing a little bit of aggravation, causing pain is not a bad thing, as we would in the early stages. So they're the findings that you would find. If there's any swelling, it's chronic, normal skin temperature, end range resistance, and very localized if there's any tenderness. Okay, so let's go back to what's happening in those stages and where our treatment comes in. So in the early stages, the bleeding stages, what we're dealing with is really hemostasis. So what we need to do is really respect the fact that what the body's doing to begin with is to stop the loss of blood. So we want that fibrin clot and coagulation to occur. So we're looking at ice, 20-minute intervals maximum. We know that if we put ice directly on skin at about the 15 to 20-minute mark, we start seeing Hunting's reaction. We don't know what effect that may have deeper in, but theoretically what's happening with Hunting's reaction is that once the temperature of the tissue drops significantly, where there's a risk of ice burn or death of the cells because of the ice, what the body does is release vasodilate in the area to try to raise the temperature of the tissue as a protective mechanism. Once the temperature reaches, then the cold reflex steps in, we get vasoconstriction. So you end up with this reflex vasodilation, vasoconstriction. So my rule is basically to avoid that. So keep under 20 minutes. And that long because we normally put some sort of padding between the ice and skin. And compression and immobilization is always an interesting one. There's always many different guides as far as how long you should immobilize for, and I think it depends on the extent of the injury. If you have a significant bleeder, then I'd be looking at 2 or 3 days of rest, immobilization of it to really give that hemostasis a chance to occur before we then push into being aggressive with them. We keep away from NSAIDs. Spending a lot more awareness now that, as Dr. Heyman said about the role of inflammation. Initially there was much argument about the notion that the inflammatory response that we see in a sporting injury is in fact excessive. It's over the top. The notion behind it is when we have ruptured blood vessels, the body's defense mechanism is I need to, if there's broken blood vessels, there's a chance that the skin's broken. So what I'm going to do is I'm going to swell the area up. I'm going to try and get as much blood into the area. I'm going to get as much swelling into the area so that I can dilute any bacteria that's in the area, so they don't start developing and start breeding, etc. We're having a wound. So I'm going to try to dilute them by the swelling. Obviously, in a sporting injury, you don't have that risk of bacterial infection in most cases. So the need for the inflammation, swelling, etc., the need for swelling's not as high. But definitely there's a need for some of that inflammatory process. What we're seeing in some of the, particularly the recovery from sport, there's some really interesting stuff happening there, is showing that if you use cold cryotherapy and cold post-exercise, that in fact the muscle doesn't grow. You reduce the DOMS, so you reduce the delayed onset muscle soreness, but the muscle doesn't strengthen, doesn't hypertrophy, the same as it does in those who don't use cold and ice. And the suggestion is that the ice, or the inflammatory process, is the driver for that muscle regeneration. It has a in that. So likewise with the healing cascade, is we need a little bit of inflammation to occur. So we need to respect that to allow us to get good collagen laydown, good healing in the area, good lot of collagen type 3 to then progress to collagen type 1. So we don't want NSAIDs which are going to affect the prostaglandin synthesis, which occurs early in the inflammatory cascade, and reduce the amount of scar tissue. So with the inflammation, the inflammatory response is very much vascular and cellular response. It's a vasodilation, vasopermeability, tissue edema, and it's about killing the bacteria, and that's the neutrophils, which are usually in the first day or two. Once they go, the macrophages move in and they clean up the area. So at that point, so after about 2 days, once we've got the neutrophils out of the way, then we actually want to start some movement, because at that point, what the evidence is showing that we're getting mechanotransduction, which is that the inflammatory process is actually increased. So it's a cascade. It passes through. It's optimized. Is the word. I was trying to think of the word for it. It's optimized with some movement, provided it's within controlled pain levels. So it's only a little bit of discomfort at the most, but you need a little bit of movement through there, because that facilitates this process of cleaning the dead tissue and laying down new tissue, which is the proliferative phase, the next phase. So you're getting collagen laid down, that type 3, you're getting myofibroblasts in the area, and you're getting angiogenesis occurring. So we think, well, we find that that's being increased by movement, by activity. Okay, sorry. So what's our goal in the first 72 hours? We've done the ice, we've done the cold for the first 24, 48 hours, depending on the severity, etc. We know in the ice regime, etc. Doing that. What we really want them to do is obtain a pain-free and normal walking gait as early as possible. So we may need to use crutches if it's a really bad one, but we're going to try to encourage them to walk as normal as possible. So they maintain good hip movement, etc., good hip stability. They may need to shorten their stride lengths, so they're not stepping out too much. Be careful of walking up hills, etc. So we're going to make sure that they don't overdo it with their early rehab as far as from an exercise perspective, but we are going to encourage them to try to walk as normally as possible. We're going to commence controlled activity to maintain hip pelvis control and functional activation necessary for hamstring. So we might get some low intensity sidestepping, so lateral movement. So we would get them doing stuff which is going to, rather than sagittal plane coming forward, is actually going, rather than frontal, is actually going sagittal, going sideways. So lateral movements. We want contraction in the hamstrings. We want them to be working, but not in a really painful way. So we want some mechanotransduction. So I don't want to be stretching it. We want just to get a bit of movement. So we may do a low agility step, so just stepping forwards and backwards and sideways, just within pain-free range. not only in the affected leg going forward, but the affected leg actually weight bearing and making sure they stabilize the pelvis as they do it. I think that's probably one of the biggest issues in the long-term rehab, particularly with athletes, is that we protect, etc. We focus on the hamstrings, we forget about the pelvis until 3 weeks down the line, in which case then it's already starting to weaken. And it can be a very subtle weakness that doesn't present again until they really push themselves at 110%. So the more we can do things such as single leg balance off that leg, provided it doesn't, and standing prone hip extensions, again, we're not working too hard against gravity. And the one I would be pushing would depend on where it was. So if I had a distal hamstring tear, or a strain, so in the semi-tense, semi-mem, or the biceps femoris one, so more towards that eccentric swing phase, I will be doing the prone hip extension ones with the knee straight. If I had a more proximal one, so biceps femoris, more from the push-off one, then I'm going to get them to do knee flexion. So I'm going to try to, in this early stage where I want mechanotransduction, because I've got a two-joint muscle, what I'm going to try to do is keep the area where the injury is not working and work the other end, if you like, to start getting the movement. Same deal we would do with neural stretching and manual therapy. If you've got something close proximally, you start distally, where you're starting to get mechanotransduction occurring, but it's not going to aggravate it to the same degree. So it's about this notion of controlled inflammation, controlled aggravation. Core control obviously is very important as we go through, so the whole way through. So we're going to do prone abdominal hold, so looking at planks, do planking, we might do bridging holds, particularly on the unaffected side. Single leg ones could be side abdominal holds, push-up stabilizers with trunk rotation, so we're doing a lot more core control, a lot of pelvic control, try to get to really build up that core stability, so and build up that pelvic stability, because we really want the base from where the hamstrings come off to be as stable as possible during functional activities. And I always wonder how much, when we're doing this with patients, in fact we're probably doing stuff that they should have done, they probably were weak before the injury. As we've shown, it's a risk factor before. And so this is a good opportunity really to catch up on this area so that they have less chance of recurrence down the line. And then having some form of recovery, and that's putting ice in a long sitting type position in the early stages for up to 20 minutes, so that it's in a stretch process. So, but not a little bit, not too much. We're trying to settle it down a little bit from what we've done. And I'd only do the recovery, the ice, if we overdid it a little bit. And this is not uncommon early on, and the patients will tend to push themselves, particularly athletes. Most patients I would tend nowadays I don't tend to use ice, etc. in the recovery phase, tend to back off with the exercises and progress it more gradually as we go through. And what I'm really guided by in the progression of the exercises is not so much the soreness while they're doing it, it's what they feel the next day. They wake up next morning and they're a lot stiffer and sorer. We need to back off the number of reps that day. So, and it's very difficult to work out with patients apart from trial and error. And there's some areas you do through there. So once they can do a kind of like a controlled running drill, which I'll show in a second, without hamstring soreness the next day, without reducing their speed, they're just doing a steady pace, then they can progress through to more aggressive running stages. But at this stage, so they're progressed through with those exercises, they're settling down, you're increasing the stretching as well. The stuff I didn't put in there, sorry, was looking at hamstring stretches. Both, again, stretching both sides. So to stretch hamstrings, I always say there are 3 hamstring stretches. One is lying on their back, or they can do it in standing, but with their full hip flexion and then straightening the knee. So you're pre-tensioning the proximal aspect of the hamstring and then increasing the distal as one stretch. They then need to come back, pre-stretch the distal to keep their knee straight, and do basically a straight leg raise, where they're then tensioning over the hip joint. The two are completely different stretches. And if you do it yourself, you'll feel them in different areas when you do the stretch. So it's important that you stretch both ways. And I said there were 3 stretches. Every hamstring patient I get gets slump stretch as well. It's just so commonly involved that I think it's an important, when they do the stretch, they do the straight leg raise with the knee straight, hip flexion. They do that as a stretch. Then the next time they head down, toes up. So they actually increase the neural tension associated with it as well. So every hamstring patient for mine gets the 3 stretches because they are completely different stretches. In the early stages of that inflammatory cascade, I will stretch the one which hurts the least. So if I've got, and usually for me, the distal hamstring, if I have semitendinosus, semimembranosus patient, will be better with the straight leg raise. If you've got a higher one, biceps femoris, then I'll tend to concentrate more on the stretch till the full flip flexion as far as they can go, and then just add the knee extension at the end there. So be guided by patient symptoms. So when you're doing both of those stretches in that early inflammatory, the early stage, see which one hurts the most or they get stronger sensation, get them to do the other one more, at least twice as often, that one there, because you're stretching it, but you're not putting too much tension through that area. As the inflammatory cascade resolves, as their latency resolves, then start introducing more of the other one, so that you can actually be more specific over that area. From probably a week mark down the line, when they're very much, most young fit athletes would be in their proliferative phase, then I would be stretching for trying to really get where they really feel it over the area, because I'm really wanting to stretch those fibroblasts as they're actually healing. So controlled running drill that I normally do with them and get them to do themselves is a walk jog. It's not a run, it's more of a jog. And that they can start this as a walk, remembering that the walk was a high part of what we're doing. So usually this would be, I reckon, within a week, most patients would be back into this, at least walking this, and trying to break into a jog with it when they can. So they've got a 50, 60 meter side walk where they're purely walking, and then the 80, 90 meters where they can walk, and if they feel up to it, a light jogging. So once they can do 6 to 8 reps of that, where they jog the 90 meters and walk the 50, 60, then they can start into a running drill. The drill that I use is an acceleration, steady state, and deceleration phase, where so they're set in meters, and it's in 3 stages. So many meters of acceleration up to a point, steady state for that much, and then decelerate with a day on, day off protocol. So they never run on consecutive days. And because the cost for me is on the second day, that's the day that's most important. How they wake up the next morning tells me whether they can cope with what they're doing. While they're doing the run, and likewise with the previous run protocol, previous controlled walking protocol, 2 out of 10 is okay pain. I would not, with a 0 no pain, 10 being the worst pain they could ever imagine. It's like getting their legs chopped off without anesthetic, that they can exercise at a 1 to 2 out of 10. They need to start feeling it in the area, but they shouldn't be so much that it's hurting. It should be discomfort. So 1 to 2 is the discomfort. So so when they're running, and this is the first 80 meters is in a 30, 30, 20, 30 meters accelerating, 30 meters start, and 20 meters decelerating. Decelerating is important because that's working that eccentric control. Walk back recovery, have a rest 4 to 5 minutes between sets, make sure they have good technique. So they may need to shorten their stride length to cope with that, and their speed associated with it. And then once they get good form, and form's the most important thing to begin with, then they can increase their speed as they go through. Progressing it, depending on tolerance, again, giving it the day's break in between. If they feel okay, then we'll push them. The time I'd stop is when the next day they wake up and they're a bit sore in the area. we've pushed too hard. We stop at that point there till they resolve with it. So this is sort of the guide that I would use as a rough guide. 30, 50, 20, 30, 70, 20. So you're increasing the steady state in the middle. You've still got the acceleration and deceleration phases being the same. Then you can progress the pace up to 80, 85, etc., and work your way up speed-wise. So that's a protocol that I would use for hamstring rehab. You continue with your strengthening, so with bridging, double leg, single leg, etc., which I'm sure a lot of you would do these exercises. So really trying to push the core stability and the hamstring activity. Hamstring curls. So I like to get people in the gym doing hamstring curls, like double leg, single leg, using 2 legs to lift up, 1 leg to curl down. So focusing on the eccentric and single leg dynamic. We're getting close to the end, are we? Sorry. It's how much time I had? My clock isn't working at the moment. How much time do I have, Dr.
We have exceeded the time by about 3 minutes now.
Oh, sorry.
But it's okay. I would like you to sum up.
Okay. Can I run through the next bit just very quickly?
Yes, please.
So, Nordics are important. I'll push this through the exercise. The main reason I want to push on this is the Nordics are very much a knee-dependent exercise. So think of your sport that's associated with it, because for us, Australian rules football, everyone does Nordics, but it's a very hip-dependent activity. So there's an article there that I would get you to read because I think it's important from that side. Prognosticators, if they've had a past history, unable to walk, then they're independent predictors within 24 hours of injury as being slow recoveries. And what we're showing is that that's actually due to an intratendon tear, which is the MRI. We talk return to these are the involved. Any inability to complete training, they wouldn't go back. Older players would delay the return to sport. If they have normal ultrasound, could do all that, then we get back to sport earlier, particularly semimembranosus. Biceps femoris tend to be a little bit slower, in my experience. And we use a lot of concentric exercises, isometrics and isokinetics to determine when they get back. So open to questions. Sorry about that.
No, sorry. In fact, we're sorry, Steve, to have interrupted you in between.
No, that's cool.
So, Steve, first of all, thank you very much for a very, very informative session and an insight into the hamstring injuries. We have 2 or 3 questions which we would like to discuss with you. And one of the first ones is on one of your last slides, you mentioned that you look forward to 5% differences between the injured and the. So, but there has been a lot of debate on what sort of limb symmetry index should we choose. So are we saying that you're going by like 95% limb symmetry index in terms of isokinetic and isometric measurements?
Yeah, we've moved more towards coming back to isometrics now. So and I think the technology is a lot better now with isometrics and a lot more mobile. So we use a lot of fixed dynamometry in our national football team. So I'm involved in one of our local clubs, which is in our national league. So we use a lot more fixed dynamometry, and we look for about a 5-degree difference as a guide between the 2 sides. What we also find, particularly if you can work with the team, is actually we have normative values on all the players for all their isokinetics or isometrics. We focus on isometrics, and what we aim for is they don't go back until they're within 5% of their normal. Back to training. So we've actually returning to we also use that in the recovery phase as well. So they don't come back till they're within 5% of their normal.
Thanks, Steve. So is there a particular angle at which you perform these isometric dynamometry?
We do it at about 45-degree and 90-degree hip knee flexion. So we tend to do we have a number. We use a system called Kangatech, but which is basically fixed dynamometry. So we have a number of different routines. One is with the knee at 45-degree, one's at 90 degrees, and then we have a claw one, which is because I think the hamstrings don't work in isolation. We're becoming a lot more aware of the whole posterior chain and the idea of calf, hamstring, glutes, all working together in fire. There's a lot of research coming out now about firing of the glute med at the right time, etc., leading to potential for hamstring injury. So we use a claw technique where they actually work their hamstrings, their bridge, and use a bridge and the hamstring at the same time. Try to also look at that strength as well. We find that quite useful.
Super. Thanks again. Just another quick question before the coordinators from the SRP will, of course, have a message about the time that we're using.
Okay.
A quick question on MRI. I
Yeah.
mean, in your presentation, you mentioned that the intratendinous injuries, the part of the tendon getting injured into the muscle,
Yeah.
they have a relatively poor prognosis compared to other muscular injuries.
Yeah.
For which MRI scans you mentioned could help anyway. But when you see these patients, how do we come to a conclusion that which patient would probably need an MRI scan, considering that we can all of them scanned
Yeah. Oh, absolutely.
using an MRI?
And that's right in that slide there. It's usually within the last, if they're not able to walk relatively normal within, and I said to her, but within 48 hours, if they're not able to walk relatively normally, and that's, I mean, they might stride length steps, but should be able to walk normally. They should be resolving fairly quickly by the 48-hour mark in most patients. If they're not, if they're staying high, then that to me would be a flag for sending off for MRI. Yeah.
Super. Steve, we also have a question from one of our audience, and the person is asking, in your practice, how many individuals have you seen developing hamstrings injuries where you can sort of say that the reasons could be gluteus strength or inhibition?
Yeah. The problem is with any of this stuff is I wasn't able to see them before they had their hamstring injury. So the ones I see in clinic, I see from a hamstring, I wish I could, and that's, I think there's definitely something to do with the pelvic instability, but it's often hard to know. It's still on a hypothesis category. We're still seeing it, so we treat it, and they get better. And I keep my fingers crossed that it's due to that. But realistically, from a scientific perspective, I haven't seen you don't get to see them before the injury usually.
I totally agree on that, because it is very similar to scapular dyskinesia, where we say what comes first. I mean, is it shoulder pain or dyskinesia?
Yeah, exactly.
So it's the same thing like that. So
yeah, it doesn't mean you shouldn't treat it. What I'm saying is,
of course.
you treat what you find, but you'll be very, very skeptical. You be honest about what came first. We don't know. So,
we will. That's a very tough one. Cause-effect relationship is the toughest one to find in sports.
Yeah.
So for now, we do not have any further questions from the audience, and neither do we. And it was once again a very, very informative session on hamstring injuries. And thank you very much, Steve. And I would like request the SIP coordinators to take over from here. Thank you very much, and thank you to all the audience who've taken our time on a Sunday.
Thank you.
Yes, thanks a lot, Steve.
Cheers.